Our next speaker is Ramy Ibrahim, who is Clinical Vice President of Immuno-Oncology at AstraZeneca.
All right. Good morning, everyone. So we're going to switch gears a little bit and start talking about safety of immunotherapy. I don't have a disclosure slide, but I'm a full-time employee of AstraZeneca. I'm not going to talk about any of the AstraZeneca products in this presentation. Just as a background, we always hear about immune-related adverse events. Basically, they are a very nonspecific inflammation. And here, those are a couple of slides that demonstrate this. One of them is a biopsy from a patient who developed colitis on an anti-CTLA-4 antibody. And we can usually, the reports that we get from the pathologists when we send them the specimen is that there are lymphocytes, eosinophils, so a very nonspecific inflammation. On the right side here, this is a biopsy from a patient who developed dermatitis. And we can see here that there are some CD8 specific T cells. So the safety profile of those agents can be explained by the mechanism of action. We are inducing a nonspecific activation of the immune system. Yesterday, we've heard great talks about mechanistically how different agents can lead to an activation of the immune system. Based on the totality of the data that we have seen so far, there are some organs that are more prone to developing those toxicities. The most common one is the GI tract, and patients can present with diarrhea or colitis. We've seen patients who will have some dermatological adverse events like erythema or rash. The liver is another organ that's commonly affected with those agents, and patients can present with very asymptomatic transaminase elevation. There were reports of laboratory pancreatitis. Endocrine system is another organ that can be impacted where patients can present with any kind of an endocrinopathy, and usually the presentation is very vague. But the key message about those adverse events that they can occur at any organ, not just those organs that are commonly affected. One of the other challenges about those adverse events is that the time to onset or the time it takes until the event starts to manifest is very variable. It depends on the organ affected. It depends on the molecule being tested. And this was just a summary of some of the data that was generated early on with ipilimumab, the anti-CTLA-4 antibody. And we can see here that for the skin adverse events, they are usually seen early on, but something like the liver or the endocrine adverse events have a more of a delayed onset of those toxicities. And again, we heard about this yesterday. So when we start thinking about the management of those adverse events, as I mentioned, they are basically nonspecific inflammation, and it can be explained by the mechanism of action of those molecules. In most patients, those events are low-grade in nature. And again, in many patients, they can be manageable and reversible. The management guidelines have been established, and this is based on the data that was generated from multiple agents, and they have been used in clinical trials. In most cases, the events, if they are properly managed, they are reversible. And the idea behind managing those adverse events is very simple. If it's a nonspecific inflammation, then we start giving patients some immunosuppressive to reverse this inflammation. But if they are not properly managed, either the symptoms will worse, and in some cases, patients can present with some complications. So a patient who's presenting with a low-grade diarrhea with an underlying colitis, if this is not properly managed with the corticosteroids, this can rapidly progress, and patient can end up with a perforation. As I mentioned, those management guidelines have been developed, and they have been used in all of the ongoing clinical trials. And the concept behind them is very simple. It's just all about vigilance, early recognition of the signs and symptoms. We have to really rely on the patient education. So here, the patients are our partners in trying to identify and managing those adverse events early on. If the event is a low-grade event in nature, the management is usually symptomatic therapy or topical therapy. But if it persists, or if the patient event worsened, or if the patient presents with a severe event, then the management is usually systemic corticosteroids. And this is a very simplified schema of what medical oncologists should be doing when they are treating patients with immune modulators or immunotherapies. Obviously, the first step is the diagnosis, so identifying the adverse event. We recommend that if there is an adverse event that's suspected to be immune in nature, that they hold the study therapy. There are toxicity management guidelines, so always go back to the toxicity management guidelines as a reference. Work up the patient to try to identify any obvious alternative etiology that might explain why the patient is developing this toxicity, and then early intervention with steroids. Again, it's a very simplified algorithm, but if it's followed, in most cases, patients can continue on the treatment. So what I wanted to focus over the next few minutes is around some of the challenges that we're facing with those adverse events. The first one is identifying them. When I started looking at the different approaches for identifying adverse events, and I looked at some of the labels that are currently available, there are different permutations of the definition of an immune-mediated adverse event. Some of them is an anti-inflammatory event and there's no alternative etiology that can explain this event. Others are anti-inflammatory events that, again, in the absence of any alternative etiology, but that was managed with corticosteroids. And then there were other events that were characterized as any toxicity that was managed with corticosteroids. So this by itself poses some challenges for us because we don't have a consistent way of defining those adverse events. Even the terminology that we're using to characterize or to describe those adverse events is not consistent. There are reports of immune-related adverse events, immune-mediated adverse events, or events of special interest. So as a medical oncologist, and I'm trying to read the labels, there are some differences between one molecule and the other, although both of them target the same pathway. And then one of the other challenges from the clinical trials is, do we rely on the investigators' assessment for the causality, or we need to have an independent review of those adverse events? And then the other piece that is very key for those toxicities is the patient education. Most of the events that are associated with immunotherapies cannot be identified during a regular physical exam. So for example, a patient has to come to you and tell you that I'm not feeling myself, and that's a sign that there's fatigue, which could by itself be a reflection of an ongoing endocrinopathy. Again, abdominal pain with an underlying colitis or just skin toxicities. So the patient is the first step in us identifying those events. But one of the challenges that we face with many of our patients is that patients are reluctant to come and report those events. They are worried that if they tell their oncologist that they are having adverse events that could be related to the drug, they will stop the treatment. So patients in most cases will start using some remedies or over-the-counter agents to try to control the adverse events, and they will only come to us when those events are worse. And then the other problem is when patients start having, say, any acute or severe toxicities, likely they're not going to go to their medical oncologist, but they will go to an emergency room or an internist because they are just complaining from abdominal pain, so they might not be seen by the medical oncologist. So, and then the other piece is when we start thinking about how are we characterizing the adverse events of immunotherapy. Most of the times we do, or we generate the safety data from phase 1 clinical trials. Our approach to the clinical trials has always been, we do a 3+3 design, meaning we enroll 3 patients. If we don't, at a certain dose level, if we don't see toxicities, we go to the next dose level. If we start seeing some unexpected toxicities, we expand this to enroll additional 3 patients before we make a decision to go to the next dose level. But if we look at all the PD-1 and PD-L1 antibodies that were in development, none of them reached a maximum tolerated dose, and all patients who were in the phase 1 studies well tolerated the treatment. So when we start thinking about what is actually the safety profile of those agents and what's the appropriate dose that we should be taking, we cannot just rely on the 3+3 design. We've heard it yesterday a lot about the different onset of the adverse events. Usually in the phase 1 studies, before we make a decision to go to a higher dose level, we follow patients for a certain period of time, which is the dose-limiting toxicity observation period. With immunotherapy, it's very difficult to rely on this, given that there are some patients who might have adverse events that have a delayed onset that will not be captured during this dose-limiting toxicity observation period, which again, it puts some limitations to what we can do with the current designs of the phase 1 studies. So it is very important when we are trying to characterize the safety of those agents early on is to look at the totality of the data, not just the few weeks that we use in the DLT observation period, but we really look at the totality of the data from PK, from PD, efficacy, and safety before we make a decision for either dose selection or dose escalation. One of the other challenges with the phase 1 studies is quite often we select investigators to participate in those studies that have experience with immunotherapy. So they really know how to identify those events. They really know how to intervene and manage those adverse events. But that might not be the case once we start doing larger studies, and obviously not the case once the drugs get marketed, where investigators who have less experience will start treating patients with those agents. In the clinical trials, we do use the management guidelines, and there are very strict criteria about who can continue the treatment, who discontinues, and how to intervene if you start identifying some of those events. That's not the case in real life when actually medical oncologists are treating patients outside of clinical trials. And obviously in the clinical trials, those are very closely monitored environments. So the other piece is the real-world evidence. As I mentioned, there are some cases where after the drugs got approved, not particularly with immunotherapy, but in general, once they are in the hands of the general community, the safety profile can be different from what was reported in the clinical trials. One of the biggest challenges is that those adverse events are not usually managed by the trained medical oncologists, but rather they are managed by internists, gastroenterologists, endocrinologists, who might not have the same level of experience as medical oncologists. The other challenge that we have is for the non-experienced oncologists. They are usually very reluctant to give patients immunosuppressives because they know that they are treating the patients or treating the cancer with an immune modulator that should be activating the immune system. So it's counterintuitive that we start giving them immunosuppressive. So for most, they might be reluctant to give immunosuppressive to treat the toxicities. So just, again, to start thinking about a framework for detecting and characterizing the IREs, we need to have a standardization for how are we defining those adverse events. And again, that will include input from regulators, academics, and industry representatives. We should also consider including a separate term for the immune adverse events in the CTCAE criteria that we use to characterize the adverse events of agents in clinical trials. We have to start thinking about novel ways of designing phase 1 studies to characterize the safety of those molecules. And the other thing that's quite often not utilized is the peri-approval data. So once the phase 3 studies are done, and before the agent gets approved, there are expanded access programs. There are other ways of patients having access to the agent. And I think that's a very rich database that we can leverage to further characterize the safety of those agents. We need to start including more community hospitals and oncology units in the clinical trials to gain the experience early on. And obviously, there's the investigator's assessment versus independent assessment. Patient education, we really need to make sure that the patients are aware of how important it is to report those adverse events early on. And then the other thing that is key is trying to leverage the patient-reported outcome and quality of life rather than just looking at what's the investigator assessing as related to treat or study drug or not. And then obviously there's a need to expand the awareness outside of the medical oncology field. When we develop the management guidelines and educational material, our focus is usually the medical oncologist, but we really need to start expanding this to internists and specialists and the emergency room physicians. Right? Thank you.